Welcome to Ask the Experts, an MS Perspectives webinar for people living with multiple sclerosis and their care partners. This webinar is hosted by the Consortium of Multiple Sclerosis Centers and Catamount Medical Education and supported by grants from Mallinckrodt Pharmaceuticals and Sanofi. Our session for tonight will begin with questions submitted prior to our event. The questions have been grouped by topic, so while we may not answer each one directly, you'll hear responses that cover the most common topics submitted. These include questions related to new diagnoses, treatments, aging, comorbidities, rehabilitation, and mental health support. We will then move on to questions submitted by you tonight. To ask a question, please click the Q&A button at the bottom of your screen and type your question. We will do our best to answer as many of your questions as possible tonight. Our moderator today is Dr. Samantha Roman, a board-certified neurologist with expertise in managing MS. Dr. Roman also brings her own perspective as a person living with MS herself. Joining Dr. Roman is Mary Jean Biusi, a nurse practitioner who has been caring for people living with MS for most of her career, Patricia Bobrick, a physical therapist with a special focus on MS, and Dr. Megan Beyer, a psychologist with expertise in cognitive and emotional disorders in MS. Our panelists all bring extensive experience in MS research and care and are excited to answer your questions tonight. Let's begin.
All right. Thank you all for joining us tonight. We're very excited to be here with you, and I think we're going to have a really nice conversation from various perspectives about all things MS. So to kick it off, we wanted to start with a question we get asked frequently, that comes up in clinic frequently, and that is, what would we tell someone who is newly diagnosed regarding MS and about living with MS? I was going to start by just sharing that I typically start with acknowledging that it is a very scary thing to hear for the first time that you have multiple sclerosis, especially if you've never been diagnosed with a chronic illness. And I know in my personal experience, something that helped me early on was my neurologist said, there are a lot of people walking around in this hospital working with us. You'll never know they have MS unless they share it with you. And I think it is very scary, but at the same time, there's hope, because we do have a lot of really effective treatments today, which really changes the outlook for people diagnosed today. The other thing I tell people is not to compare themselves to others with MS, because everyone's MS is their own journey, and it's really hard and nearly impossible to compare what you're going through to somebody else, even if you have the same disease. And then lastly, that lifestyle things are very important. Diet, exercise, as much as, we can partner together and create a good plan for medications. Keeping yourself healthy with the food you eat, exercise, good sleep, all is super important. And so I kind of try to take a step back, a little bit of a holistic view of everything, and say, this is really scary right now, but we're going to get through it together. We're going to come up with a plan, and we have some really great treatment options. So I like to keep it I like to keep it optimistic, because I think it is an optimistic time to be in the MS sphere, and it's one of the reasons why I love what I do. So I don't know if anyone else had anything to add to that question before we move on to the next.
The only thing I would add is something that, as a provider for a long time, we've said, you see one person with MS, you've seen one person with MS. And just like Dr. Roman said, it's so true, because everybody's journey is so different. You may have same symptoms, but the way they're affecting you could be differently than somebody else. So there's so much hope, because the treatments are so individualized. We can individualize the treatments now, and we'll talk about that later, but I totally agree with what Dr. Roman said.
Excellent. Well, leading into the next question a little bit, that I'm going to ask Megan to weigh in on is, what kind of emotional or mental health support is available or important for someone newly diagnosed?
Great. Thank you for this question. I think it's a really important one. I'm going to start off by saying that many people with MS, I'd even hazard to say most people with MS, are quite resilient and actually do well emotionally over time. That being said, I'm going to share two things that kind of seem like they're opposites, but probably, but can both exist at the same time. And you're going to see that these kinds of ideas happen all the time with MS, that two seemingly conflicting ideas exist at the same time. One is that 50% of people with MS will experience some form of depression in their lifetime. A third of people with MS will experience some form of clinical anxiety in their lifetime. And most people can be resilient. So those things seem to be in conflict, but actually they can both exist at the same time. So what do? We want to build resilience. Resilience is your ability to bounce back when things get hard or when something unexpected happens. Resilience can be grown over time with different strategies, like giving yourself rest days, understanding what really fills your cup. So really trying to understand what helps you to feel like you can be more resilient and bounce back after hard days is a great thing to learn early on. Understanding your values is something that I often do with people. So if you love helping people and your career has been focused around helping people, and maybe someday you might think about transitioning away from that career for many reasons. Maybe one of them is MS. How can you continue to help people uh, even after you're transitioning away from that vocation? So your values are that tie, that string, that thread that goes throughout your life, regardless of what you're actually doing. And so better understanding your values can be something that's really important. And the final thing is that there's lots of uncertainty in everyone's lives. There's lots of uncertainty living with MS. And so there's the term that's been studied in medical populations called tolerance of uncertainty. Acceptance and commitment therapy is one type of therapy that has been used to build your tolerance of uncertainty. So it's kind of getting comfortable with the uncomfortable. So I think if you're not quite sure how to do that yourself, working with a therapist that's familiar with ACT or acceptance and commitment therapy can be a great way to sort of build some of those muscles.
Excellent. Thank you, Megan. And I also find some of my patients do find support groups helpful, which they can find through resources like the National MS Society. On the other hand, I've also found some of my patients find them a little bit less helpful if it's more anxiety inducing than helpful. And so I often do tell people like, hey, if you're looking for support, check it out. But if it's making you feel more uncomfortable or anxious, maybe that's not for you. So I think for some people that can be very helpful.
Yeah, absolutely. I would say the one thing there is who in your life can be supportive of you, and that might be in a support group or and find understanding, right? I think when you don't have to explain yourself to somebody else, that can feel very valuable, and that could be in a support group or that could be in other places as well.
That's excellent, excellent advice. All right, we'll move on to the next question, which was about the newest advances in treatment, for example, repairing nerve damage. And Mary Jean's going to lead us off on this one.
Yeah, so there are some emerging treatments. And in fact, I think most of the MS world, um, those of us who work with people with MS, and a lot of my patients have been asking about the newest drug. When's it coming out? When's it coming out? And that's the BTK inhibitors, which is Bruton tyrosine kinase. And these are a different kind of medication. First of all, everybody's happy it's oral. It's not IV, it's not an injection, it's a pill. So that's number one. But number two, these drugs have been studied in both relapsing MS and secondary progressive MS without relapses. And that seems to be the age group that I see a lot in my practice. In fact, there are more people living over the age of 55 with MS than there are younger people being diagnosed with MS because, and I always say it's because they were the baby boomers. I'm a baby boomer, and that's what we call them. And so there's so many of us that were born after World War II, a lot after World War II. I think baby boomers goes to 60s or something. So So anyway, so there are a lot of them. And so a lot of our patients in that age group can be secondary progressive, but no relapses. And yet they still feel like they're not getting well. They're getting worse. And so these BTK inhibitors, and one may be out at the end of December. They keep on changing it. That's the Sanofi one called tolebrutinib, but it may, but we don't know for sure. The FDA is still studying it. But they can target cells in the brain linked to worsening, linked to progression. And there's something that you've probably heard of. It's called smoldering inflammation. We can't see it on MRI. We kind of sort of know it's there because the patient may be progressing. They may, well, in the past year, how far have you been able to walk? Well, my walking has diminished some. It's a slow progression. So these drugs, this type of drug seems to work on that especially. So we have a lot of people who are looking forward to that. Hopefully it'll come out. It was supposed to come out September. I think it was supposed to come out in July, and they keep on stretching it out. So we'll see. There are other myelin repair therapies that really are under study right now. They're being studied for repairing the myelin, which is the covering of the nerves, restoring neural function, and they're in various stages of research and development. One of them that's being researched right now has a strain. They don't have names. They don't call them anything. They call them Pipe 307. So if you look up Pipe 307, it's a clinical trial with the NIH, and this spurs the body to replace myelin, and it's been studied for about 10 years so far. And right now they've done a couple of clinical trials. So I'm just going to quickly discuss the clinical trials just so that you have some idea. So phase 1 is a safety, efficacy, and what dose is the best. That's a trial. It's with a few people. Just generally, it's a few people. It's phase 1. Sometimes it's 20 people. For this drug, Type 307, it was 70 people, and including 6 healthy volunteers who were okay to get that too. So it's quite amazing. And so what they found, that it was safe. There were no real side effects. It seems like the dosing was okay. So then they moved on to a phase 2, which is where they are right now. And the phase 2, it looks at a larger population. So they had 182 people. It started in 2023. It finished in August of 25, just a couple of months ago. So now they're reviewing the data. And if the data still looks good, if it's safe in a larger group, and if it's efficacious, if it seems to be working in these populations, relapsing, remitting, and secondary progressive, if it seems to be working in them, then they go to the largest trial, which is called the final stage. It's phase 3. And so sometimes we wait a long time for that phase 3 data to come, but it's so important because it monitors these drugs through a longer period of time with more regular people. So that's one exciting thing, this Pipe 307, that seems to replace lost myelin, which could be very, very exciting for people. There's another one called K102. And this one is repair and regulating the immune system. Now, wouldn't that be nice if the immune system was regulated too? But it's not yet in trials. It's slowly getting there, but it's being looked at in advanced cancer. So that's kind of interesting because many of our drugs that we have already have come from the cancer arena. We've used them in cancer, or we've used sister drugs to them. So many of our drugs have been used like that. So anyway, we'll see what happens with this one. And then the last thing a lot of people ask about are stem cells. So should I get stem cells? So then, I've had patients go to Mexico for stem cells. There are people, I live on Long Island, and there are people that advertise, we give you stem cells. Well, those aren't the right kind of stem cells. So just to let you know that I always say, don't do it. It's so much money. Don't do it. But the stem cells that are happening right now, there are some clinical trials looking at if this is good, if this works in MS. And so the research is whether they can repair, whether they can promote healing, for the immune system. And so not only are they looking at MS, and let me tell you, these studies for stem cells, various types of stem cells, there's 5 different types, have been going on since the 90s. And there still is unconclusive evidence that there's a good benefit. And they only got to phase 1 trials. They're small trials, only phase 1, and they're not quite there yet. So this is something perhaps in the future. They're still looking at it in various diseases. And that's about what we have coming up. As I said, very exciting about the BTK inhibitors and other drugs that may be in the pipeline for us. Oh, type 307, but maybe in the future for us, for our patients with MS.
Excellent. Thank you. That was a great overview of upcoming therapies. And we will see about the BTK inhibitors next month.
Right, we hope.
All right. So moving on to the next question was regarding whether MS stabilizes or slows down with age. So a lot of people are often diagnosed earlier in life. 20s to 40s is the typical age at onset of symptoms, and the immune system is very active and robust and strong, and the immune system tends to weaken as we age. So the inflammatory activity we see early on, the new relapses, the new lesions on MRI, those tend to decrease over time. We tend to see less new lesions on MRI as people age. And some people do seem to stabilize. They have symptoms that are left over from their old relapses, and they've kind of learned to deal with them in various ways, but they don't continue to have worsening. There are other people that even without new lesions on their MRI do experience worsening, and that is an area that is being studied right now as to what underlies that worsening. And there's a few theories, and there's certainly some evidence that many of these patients have smoldering inflammation or inflammation within the brain itself. There's also an idea that as people are aging and functions that normally will get harder and slower with age become even that much more difficult when you add another layer on top of that, which is MS symptoms from old lesions. And potentially symptoms from old lesions coming out as people age. So I think in general, I would say the inflammatory activity in MS does decrease over time for a good portion of patients. At some age, they find that they're kind of stuck with whatever symptoms they've got from MS. Like at some point, you may have a decline or new symptoms at some point. Many patients that I have found are kind of stable. They say stably bad, but they're stable. And then we're managing symptoms in the clinic. And so really, when it gets to that point, the focus of our management really transitions from the disease-modifying therapies to symptomatic therapies. And of course, there is ongoing research, as Mary Jean just shared, about treatments for that kind of inactive secondary progressive phase where there is worsening but no relapses. And I would see if anyone else had anything else to add regarding your experience with patients and whether their disease stabilizes or slows.
I think one thing that I'd like to add too is that that often our folks who are living with MS are, because they have a diagnosis of MS, everything is blamed on MS. And so being able to really be thoroughly evaluated, being able to see if there's some other comorbidities that are contributing to the factors or the symptoms that they're experiencing is really key, because there are some things that are not related to MS that we can really improve upon, or that they don't have to be kind of stuck with. So I think kind of being able to get out of the mindset as I have MS, so I have MS and everything I have is MS.
Thank you. Yes, that's very important. I had seen a patient who we were questioning whether there was progression of the MS, but the patient actually needed a hip replacement. And after the hip was replaced, the gait improved dramatically.
Right,
So
exactly.
absolutely. I think one important piece of MS neurology care, specialty care, is being able to pick apart what is the MS and what is not. I have found that many providers will just blame the MS for everything.
Exactly. Yeah.
All right. Well, kind of segueing into the next question, if Mary Jean's going to share with us answer to the question, should older patients continue treatment or consider discontinuing therapy?
So the answer is, I don't know. We know, we don't know. That's the answer, but I'll explain it to you a little better. Probably over the age of 65, healthcare providers in MS start thinking about transitioning people off the DMTs. And why would they do that? Well, the reason our biggest concerns is that our DMTs are not without their own side effects. For instance, some of the B12 inhibitors, such as ocrelizumab or Briumvi or any of the other ones, they may increase infection rate. Natalizumab or Tysabri patients may get PML or they may get other things. So we kind of like get a little nervous because as we age, and I'm aging with you guys, not with these guys, but with anybody else who might be aging. As we age, our immune system slows down and it's not as effective as it was when we were younger. And we do know that. And that starts happening. Well, they'll listen to me, but they say it starts happening when we're 20, but really when we're 40, 45, 50, our immune system slows down. And so that's when in the 60s, we older people without MS, just everybody in general, start getting hypertension, high cholesterol. Some people get cancer, they get other diseases, they have arthritis. And so our concern is that the DMTs have never been studied in these populations, never. And yet we're giving them to our patients. So we say, probably you should consider coming off these DMTs. The DMTs that we call the platform DMTs are the ones that we first had, Avenex, Betaseron, Copaxone, Rebif. Those are generally easy to come off. You just kind of stop if your healthcare provider agrees with you or says, suggest that's easy. But some of the other drugs that have been around longer, more highly efficacious drugs like natalizumab or Tysabri and Fogolimod or Gilenya, they have to be tapered off. And then you kind of have to go on another drug just to make sure there's not a problem with a rebound relapse from the medication. So stopping a DMT on your own because you're tired of it is probably not the best idea. You should come and talk to your providers, your nurse with MS, whoever you speak to, and say, what should I do about this? Because we really have certain ways that we have to take care of you with that. And that's why so many healthcare providers are taking our older patients off DMTs. Now, I have some patients. I saw a woman the other day. She's 72 years old, and I said, "I'd like you to start thinking about coming off this drug." And she said, "No." I said, "Okay, what am I going to say?" This is your choice essentially. So if you feel better being on your DMT and you know the risk, and we don't know the risk essentially. There may be some risk, but we'll tell you everything we know. Then that's your choice. And that's what we call in the business here, shared decision making. You decide with us, but really we listen to you. So anybody else have anything to remark on about this?
Yeah, absolutely. I agree. And I think the shared decision making is so important. And I always frame not just this decision, but many decisions in terms of risks and benefits and weighing them against each other. And for a lot of people, when they get older, it's kind of the discussions, well, you're not having new relapses, and these medications are primarily to treat that. And if they're giving you side effects or infections, then maybe the risk has become higher than the benefit, whereas earlier in your disease course, it was the opposite. Same thing with all symptomatic meds too. Are the symptoms we're treating bad enough to tolerate the potential side effects? It's always a risk and benefit discussion in really everything we do in medicine. And discussing some of our symptomatic management, next up, we're going to tackle what are some ways to distinguish between cognitive issues associated with MS and normal aging. And Megha will lead us off.
Sure. So similar to what Mary Jean was talking about, one of the first things that I talk about with my patients is that starting in our late 20s, every person, whether you have MS or not, our cognition starts to slow. So we have something called slowed processing speed. And that process continues for people with and without MS as we age. MS tends to accelerate that process for many people, and so, but not all. And there's lots of things, as Patty brought up earlier, that can actually mimic cognitive changes that we want to evaluate. So I'll talk about that in a second. But one really good way that you can distinguish between whether this is MS, healthy or normal aging, and or something else, is by doing cognitive assessments. And all of these assessments have been normed on a general population, which means people without cognitive problems have taken these tests. And we have a pretty good idea about how the general population performs on the tests. And so if you take these tests and you perform significantly below other people who are matched for your age and education, usually gender and some other demographics, then we start to think, hey, this may be MS. But we also want to look for other things too. We want to look for how's your hydration. When people are dehydrated, their cognition is not great. If they're not sleeping well, which often happens in people with MS, cognition is going to be impacted. There's some studies that show even during daylight savings time, when you have a 1 hour change in your sleep schedule, there are more car accidents. So, that a little bit of sleep loss can impact your cognition pretty significantly. We want to look at your nutrition, exercise. All these other things can have medication side effects that's been brought up already. Those things can have an impact on your cognition. And so we want to kind of pull all those pieces out, try and improve them as much as we can, and then say, hey, are we still having those cognitive problems that are there? Then you can still do things like cognitive rehab and others. But a starting place, cognitive assessments can be done with speech pathology, neuropsychology, but your primary neurologist office, your primary care doctor, they can do annual screenings that again are normed against the average population, and they can be as short as 90 seconds. So I would say screening is a good place to start. If you're still concerned, talk to your medical team about it.
Excellent, thank you. And I also find that a lot of times in clinic, when patients are reporting cognitive concerns, they're also reporting fatigue. I feel like they go hand in hand quite often. And one of the things I like to tell my patients is that not that MS isn't reason enough to have the fatigue and cognitive issues, but let's make sure we're not missing something else, because there are other things that are common. There's untreated sleep apnea, which I'll often send my patients for a sleep study. Depression can certainly impact energy level and cognition. And then different things, screening for anemia, B12 deficiency, other things that are easily treatable. And so that's how I usually try to approach that conversation as well, in addition to the normal aging question.
100% agree.
Not unfrequently, like we test ferritin and iron, and all of a sudden your iron stores are low, which means it's adding to your fatigue. So all these different tests that we could do if we know. And let me tell you, the one thing that I find in this is that it's hard to tease out which it is, because it's so often, is it depression? Is it this? Is it that? And it's so often a combination of everything. And so it's sometimes really hard to tease out exactly what's causing this, the fatigue or the cog fog or something like that. But it's probably everything.
I think this is going to be a theme for tonight, is that this collaborative care is so key in all of the symptom management strategies that we approach, that your whole team has input on what potentially might be contributing to whatever symptom you're experiencing. And we all have something to offer to kind of address that from a holistic approach.
And I have found a lot of my patients also have trouble with sleep, whether that's insomnia, often restless leg syndrome. And again, these are things that kind of overlap with the MS symptoms and sometimes are hard to tease apart. But I think sleep is so important. It underlies everything. So when you're not sleeping well, of course, you're not going to feel great during the day cognitively and energy wise. So. All right. Well, in addition to some of the symptoms we've already discussed, talking about managing pain, which is our next question. So kind of to start off with, when I was training, I remember hearing a lot of my mentors tell me, everyone told us MS didn't cause pain, and well, now we know that's not true. And we've known that for a while. But in my clinic, I'll usually separate the pain for my patients and ask, do you feel like it's more of a muscular pain? Because MS can certainly cause muscle tightness. Or do you feel like it is more of a nerve pain, which is kind of that burning or pin-like feeling, or shooting type electrical pains? And because we can manage those things differently. Obvious, and I'm going to have Patty weigh in a second on some non-medication options, but when I'm talking to my patients about pain, things that I will discuss with them and offer, first, I do recommend some of the non-pharmacologic options first, but if it comes to needing medications, there are nerve pain medicines that are actually borrowed from the seizure world. So gabapentin and Lyrica, which are pretty common nerve pain medicines, are actually very old seizure medicines. And those are typically ones that I will try if patients are really struggling with nerve pain. With muscle spasms or spasticity, that can be very painful with the muscles locking up. Stretching is important, but again, if it's more severe than can be addressed with non-pharmacological strategies, I will offer muscle relaxers. And I typically to start with baclofen. That's what I've had a lot of success with, but there are a variety. And of course, the problem with all of our pain medicines, whether they're muscle relaxers or nerve pain medicines, is that they can cause sleepiness and sedation. And so that's obviously going to be a concern if people are already fatigued. So that's often a conversation I'm having with people. And that's, again, the risk and the reward, right? What are we going to prioritize here? And a lot of times I found people have worse symptoms in the evening. And so sometimes it's just a nighttime dose of those medications that's helpful, and it can also aid sleep.
I think that I approach the symptom of pain in my individuals living with MS very similar to you, Dr. Roman, as I try to distinguish between musculoskeletal pain and whether it's that dysesthetic pain. We as rehab professionals are the movement specialists. So, is it some postural things that are contributing to a pain syndrome? Is there some compensatory strategies that an individual is using to walk or to move because there's weakness present? So, we are also the exercise specialists. So we want to address those things in an exercise program, whether that's stretching or strengthening or aerobic conditioning. Neuromuscular retraining, being able to establish better motor patterns to help that reinforce that good movement pattern. But we do have, some modalities available to us to use for pain management. TENS is very popular. TENS, TENS, stands for transcutaneous electrical nerve stimulation. It's just a surface electrode that's placed on the skin, a small amount of current. It's picked up by the peripheral nerves, then transmitted to the central nervous system. And you can kind of think of it as running interference with this pain cycle that a lot of people have established. Dry needling is very popular now. It's been seen to be very effective for musculoskeletal issues and some spasticity also, along with stretching and movement for spasticity, weight bearing, positioning out of the spastic patterns. Sometimes some supportive orthotics out of the spastic pattern can be very beneficial. Even things that we use will be like breathing, relaxation techniques that we can teach a patient for helping pain management. Megan, I know you can speak to that in just a second. Aquatherapy. But one other thing that I kind of use as an adjunct for that dysesthetic pain is what I call sensory retraining. So your brain has this great capacity to kind of stay in the same pattern that it's kind of generating over and over again. And you want to interrupt that cycle. So if you have numbness and tingling, we might be teaching you or instructing you on how to introduce a bunch of different sensory textures to that area that may be either hypersensitive or feeling abnormal sensations, so that your brain starts perceiving those new sensations. And again, feels those instead of that pain cycle for you. So those are some non-pharmacological things that rehab professionals can do, but it's always about a good evaluation.
Yeah, just to jump in, I love that you mentioned relaxation. There's lots of different strategies like progressive muscle relaxation, just typical diaphragmatic breathing, mindfulness-based exercises, autogenic training. There's lots of them that kind of train you to relax your muscles. And so for the muscle tightness, or sometimes we start to have those panic thoughts when you start to feel the pain that's coming on and you're like, oh no, I can't do this again. And when we start to have those panic thoughts, often that triggers a cascade of physical sensations, tightening of different muscles in different parts of your body in response to that sort of anxiety thought. And so if you can notice that's happening and start to relax your muscles when that's happening, then you often don't have as severe of a pain reaction as you would otherwise. So you might not think of a mental health provider as when you're feeling chronic pain, but there's actually psychologists that specialize in chronic pain who can help you with behavioral interventions as well.
Excellent.
I wish there were more pain psychologists. It's a very needed area of psychology. All right. Well, moving on to another type of symptom management. If Patty wouldn't mind weighing on approaches to deal with fatigue.
Yeah, this could take up the whole session, so I'll try to limit. We've already kind of touched on this, that it has to really be, for any of the symptoms, a very holistic approach. I'm going to talk about kind of how we approach it from a rehab standpoint, and I'll let everybody else weigh in then also. But one of the things that we can do is do a lot of education on energy management. And we talk a lot about the 4 Ps, which is planning, prioritizing, pacing, and positioning. So you look at your day, you decide what absolutely needs to be done. You prioritize those activities that you have to get done and do them when you have the most amount of energy. When I talk about pacing, and this is going to apply to what I talk about in exercise also, and we talk about this work-rest philosophy. If you have the approach of, I'm going to just keep plugging along until I have utilized all my energy reserves and my cup is empty, the time to kind of rebuild or refill that cup takes much longer than if you're pouring off a little bit of energy and then interspersing a rest, letting your cup fill up again, and then doing an activity again and letting it fill up again. So that's kind of what I talk about, the pacing, this work-rest philosophy. The last thing, positioning, and this is really a really important kind of energy and fatigue busting strategy. But if you can look at if you can kind of analyze what you're doing and find a way to do it where you conserve a little bit of energy. I'm going to use the example of taking a shower. If you choose to take a standing shower versus a sitting shower, if you sit during that activity, you're going to save 25% of the energy of that task. You have 25% more of that energy available to something that may be way more important than taking a standing shower for you. Now, that's your decision, but if you find these ways to kind of keep that energy bank higher, then you'll have more energy throughout the day for what you want to do and what's most important for you to do. I do want to talk a little bit about fatigue and exercise, because I have people come to me and say, Patty, I have fatigue, and you're asking me to use my energy to exercise. And this seems so counterintuitive to what I should be doing. I should be resting. But there's really good research to show us that low to moderate intensity exercise is actually an energy booster and not an energy depleter. But you have to do it in the correct way. So if you go out and exercise and just bust it out and empty out all that energy, you're going to come and you're going to say, I was in bed the rest of the day and into the next day, and that's not what we're looking for. So we're using this intermittent exercise strategy, and I call them almost exercise snacks. So little bites of exercise throughout the day, and those will all add up. So you can approach any of your exercises that way. You can approach strengthening that way. You can work a little bit with your strengthening, rest a little bit, go on to another muscle group, work that muscle group. A very popular exercise regimen now is HIIT, H-I-I-T, high intensity interval training. And really, it is just the work rest philosophy. You can do something for a short period of time, and there's no special formula. So it's going to be specific to you. Work hard, do something that's a lower energy or a rest period, and then go again and do a high energy. And this doesn't have to be done all right in a row. What you do throughout the day will add up. So those are just some approaches to exercise. I do want to mention here too is that, MS fatigue is real, but deconditioning is also real. So if you've changed the way that you move, the amount of activities that you do in a day, a lot of what you may be experiencing in fatigue is deconditioning fatigue, and we can bring all of that back if we do it properly. So aerobic training and working with your rehab professional to devise an exercise program that's going to work for you, not only to your specific needs, but your energy and something that you enjoy. Because if I tell you that, okay, I want you to do pool exercises and you don't have access to a pool, and it takes a lot of energy to get in your bathing suit and out of your bathing suit, that's not going to be the best exercise for you. So really tailor making something that that you can be successful in. And if you're not, then exposing you to a lot of different things. Maybe it's yoga, maybe it's Pilates, maybe it's just a class at the gym, maybe it's just walking, maybe it's doing some videos that are available online to you. So there's a lot of ways that you can execute your exercise and be successful with that. But there are a lot of other fatigue management strategies, and I'll turn it over to the team for all of their additional things.
I'll be short in keeping an eye on the time so we can keep on to get to the next all our questions in our time. But I will say that there are medications for fatigue. I will say they've been studied and in many studies not found to be better than placebo. Some patients do find some of them helpful, but I have found, especially patients who I see that I was taking stimulants, eventually you kind of recalibrate, and then you find that on the days you don't have that medication, you're even more tired. And so coming off those medications can be very challenging, and it's kind of a slippery slope. So I do try to avoid them if possible. But I was hoping we could talk a minute, and we can get back to in the Q&A at the end if there's more questions about fatigue, but about bowel and bladder challenges for people living with MS, which are very common, can sometimes be embarrassing and tough to talk about. And so I was hoping, Patty, if you wouldn't mind kind of leading off with some non-medication things patients can do for some of their bowel and bladder symptoms.
Absolutely. Within the rehab world and also in the nursing world, there are pelvic health specialists that can address bowel and bladder symptoms, and also sexual wellness that kind of goes along with that bowel and bladder issues too. So again, a thorough eval determining whether, is there a loss of muscle tone in the pelvic floor? Do you need to be doing strengthening exercise? Is there a loss of awareness, kind of that connection between brain, bladder, bowel? And so biofeedback is a technique that a lot of pelvic health therapists can use. Maybe it's spasticity, because bladder spasticity can also be a problem. And maybe it's the use of electrical stim to help decrease tone. So there's some non-pharmacological modalities or interventions that can be used, along with a lot of education, timed voiding, timed fluid intake, bladder irritants, what causes your bladder to be mad at you, high fiber diets, all of those things, which is a big key to good bowel and bladder health.
In general, I would say I find one of two issues with the bladder, and primarily the main one for many people is overactive bladder, where they feel like they need to go frequently. And even when you go to the bathroom, it's small amounts. Or not being able to, you don't know you need to use the bathroom, and then you really need to go, and you're going to have a leaking or an accident before you can get to the bathroom. And then on the other side of the spectrum, there are people that have trouble emptying their bladder. So some urine gets retained in the bladder and can increase risk of infection. And once people have kind of explored again, non-medication options and timed voiding and things like that, there are medication options really to treat both of those issues. And so I always like to let patients know that, hey, again, risk and benefit, is this a symptom that's kind of impacting your life to the point that it would be beneficial to maybe try a medication, and we kind of go over side effects to look out for. However, I also caution people that treating one of those problems can sometimes make the other worse if you have both. So if you have an overactive bladder, but you also aren't emptying your bladder completely, if I give you a medicine to keep your bladder tighter, so it's not you don't feel like you need to pee all the time, well, that might make your retention worse and you're not able to empty your bladder, and that might increase risk of infection. So if there's any concern about both of those things co-occurring, I will often enlist the help of a urologist. If you're in an area that has a neurourologist, great, but I have found them far and few between. But if oftentimes the neurologists will know who the good urologists are, or the folks that can offer some fancier interventions, doing urodynamic testing, doing bladder Botox, which is intervention to help relax the bladder muscle, which can also be helpful. So there are a lot of strategies to manage particularly bladder symptoms, which I find sometimes people are surprised to learn. So I always like to share that those options are out there.
And especially if you're sitting a lot, and this is what I find with a lot of my patients, are sitting, sitting, sitting. And if there is a disability and they're at work and they're sitting, then they realize, oh, I should probably go to the bathroom, and the bathroom's like down the hall. Getting up, oh my gosh, I should have gone to the bathroom a long time ago, and I can't quite make it there. And even if you have no walking disability, it's hard to get there. So what I just tell them, put it on your phone every 2 hours, get up and go to the bathroom. Because you know you're gonna have to go. And this way you never have that pressure when you stand like, oh my gosh, I'm in trouble now. And for those of my patients, for those of them that do that, they'll come back and they go, you know, that worked. I'm like, oh, I'm always so glad that I get listened to. Yay, I'm glad, because it does work if you actually get up and do it. And we all get busy, and we're all involved, whatever we're doing, and we just don't feel like getting up. But if you do, you won't, and you have this kind of bladder, this frequency or bladder, then you won't have an accident. That's what I found. So I think that's really important. And bowel is if you're constipated, we do a lot of diet training and stuff, which is very important. If you have incontinence of bowel, it's also something with diet training and that we can try to use. That one is the one that people don't really ever want to talk about, but because it's, being incontinent of bowel is just something that is so private, and oh my gosh. Whereas constipation, it's on TV, all the time, all the commercials and things that you could do. So, but please talk to us about both of them, because we will help you figure out the best way to manage either one of them. I think that's what's so important.
And I just wanted to highlight too that Samantha brought this up at the very beginning, right? That these can be embarrassing topics or topics that are uncomfortable to talk about. And reiterate what Mary Jean shared there, that even if it feels uncomfortable, trying to push through that discomfort and bringing it to your medical team can be really valuable, because there are quite a few things that can be done. And I've worked with people who became almost agoraphobic, didn't want to leave the house because of bowel and bladder issues. And when they were able to work with their medical team or specialists, were able to have some really positive benefits. So definitely bring it up, even if it feels uncomfortable.
All right, that was an excellent question. We all had something to add. All right, so the next question we had was how menopause affects women with MS. Mary Jean, if you wouldn't mind starting us off.
Yeah, and I'd like everybody to join in. So it doesn't even start with menopause. It starts with perimenopause, and perimenopause for many women starts in the 40s, and then there's a gradual transition leading to menopause, which is generally 51, 52, age 51, 52. For some people, it's earlier. For some people, it's later. A lot of times it depends on your history, your parents and their parents, etc. Your mom. So, but the thing with this, and actually we're just starting to really, in the MS world, to really understand how perimenopause and menopause can affect women who have MS. So it can mimic, they both can mimic and worsen symptoms of MS, such as cognitive impairment, depression and anxiety, sleep disturbance, fatigue, and bladder problems. So all the things we've already talked about can be worsened during perimenopause and menopause. And when we think about the perimenopausal time period, and then actually the menopausal time period too, when we do think about that, that's when we have to consider things like hot flashes and night sweats, which disturb people's sleep. It disturbs people with sleep, women's sleep without MS. And could you imagine what it does to women with MS who already have sleep issues? And all these symptoms contribute to, as I said, sleep, mood, energy. Energy. So many of my patients have no energy in their 40s and 50s, and they think they're getting worse. And so one of the things that we have to tease out is, are you having a relapse? Or is this perimenopause and menopause? Because some of these symptoms can be new to you and you don't really know that you're going through perimenopause. So it's an interesting thing. You might think you're having a relapse also when we're saying, I don't think so. I think it might be this. And then also, of course, there's during this time period for women, there's reduction of the hormone estrogen, which can lead to these symptoms and include headaches and mood swings and painful sex. So all of that, sorry, is all kind of can all kind of be messed up with MS, right? So as I said, they can mimic the symptoms of MS and amplify those symptoms so that you think maybe I'm having a relapse. So I've just started discussing that with my younger patients who are in their 40s going through perimenopause, and the ones who are in their 50s going through menopause. And so what we're finding is that what I tell them is go to your gynecologist. If they want to start you on a hormone, it's okay. You can start on hormones. It shouldn't interfere. And we go over the medications. So it shouldn't interfere with what you're taking now. Make sure it doesn't. And then they're generally safe that we know of up to at least age 55. But I would never start a person on that, but I would send them to their women's health provider, gynecology, to discuss that. And many gynecologists are very aware of that also. So that is one way that menopause can be managed, perimenopause and menopause can be managed despite living with MS. And what we don't want you to do is feel worse over these 10 years or so. I mean, it's a long time, it's a long stretch. And anybody else?
Yeah, I've had patients tell me that when they get hot flashes, all of their MS symptoms get worse because they're warm and they're heat intolerant.
Mhm.
So that can certainly happen, and that doesn't necessarily mean that the MS is active, but again, it's kind of more of one of those like a pseudo flare type of phenomenon. But certainly, this is an area that needs to be researched more. As more people are aging with MS, it's something that we're asked a lot, and there's not great research to guide our decisions or recommendations, but I agree. I usually will defer any hormone replacement management to the GYN team.
Mhm.
It's just not within our wheelhouse and what we were trained to do.
No.
All right. Excellent. So next we'll talk about what can be done to help with mobility challenges, including walking difficulties, imbalance, and foot drop. And if Patty,
Well, yeah, that looks like me. I just first want to say that mobility is a really big topic. Mobility is everything that we move. So a lot of times we talk about mobility and people mean only walking, but it means about rolling in bed and getting out of bed and getting up and down from the floor and negotiating stairs or different environmental challenges. So it's much bigger than just the skill of walking, but we will talk a little bit about walking. And I sound a little bit like a broken record, but a thorough evaluation by your rehab professional is really key, because to really identify what muscles are tight, what muscles are weak, where is your balance, what are you doing as far as aerobic conditioning? So looking at all of those facets, is there sensory loss that can impact how you're feeling and how you're moving? Have you developed a compensatory strategy that we have to kind of break out of that? So being able to kind of pinpoint where the issues lie, and developing exercises or functional skills practice in those areas are really, really key. I always give everybody a home exercise program, so you're never going to leave me without having a program for stretching, strengthening, aerobic, and for balance. And then we work on what I call part practice. So if we are looking at the skill of walking, kind of take a look at it from the whole top to bottom, bottom to top, and see what parts are missing, and break those parts down into even smaller pieces. So you go to the kind of the lowest level of what you can do with good quality, and you practice that, and then you build on that. So let's just use an example of I'm trying to improve how I take a step. That involves bending your hip, bending your knee, lifting your foot, standing on one leg and balancing, stretching your leg out, having your heel come in contact with the foot in the floor. So we may take any one of those parts of that walking cycle and use that as part practice to help build those foundational skills for improved walking. Now, a lot of people do experience foot drop in MS. And again, I don't always just slap everybody in some type of orthotic. We try to strengthen. We can use electrical stim to help kind of activate the muscle. But sometimes we do need assistive devices, and we need orthotics. And they've come a long way from when I started practicing. They're no longer the double metal upright braces, but we use really lightweight materials, carbon fiber materials that will fit into the shoe for AFOs. But there's also, I'm going to say, newer technology. It's not that new anymore, but functional electrical stimulation that's coupled with the gait cycle is a really great tool for helping you improving your walking pattern. There are a couple of different companies that are putting these FES units out, INS, Cynet Sleeve, and they're actually timed with your walking cycle. So the electrical stim will turn on just at the proper time to help lift up your foot to get your foot cleared and step through. So again, being fully evaluated and seeing where the problem lies, using exercise strategies, and then using the technology and the assistive devices that will help your walking pattern are really key. And then being able to share with your rehab professional what your specific goals are. Is your goals to walk further? Are your goals to negotiate different obstacles and to have that worked into your therapy session? So it's really about what's most important to you and for us to work with you for you to be successful in that area.
And along those lines, another additional question was, would I benefit from additional physiotherapy?
Wow. Yes. Well, let me explain kind of my philosophy of care when it comes to MS, and kind of this ideal trajectory of rehab interventions along the course of your lifetime living with MS. I'm a big proponent of early intervention. So soon after your diagnosis, you meet with a rehab professional, even if you don't have a long list of symptoms, to have baseline information taken. So we know where you're starting at, and then you're able to develop a rapport with your rehab professional. At that visit, we'll talk about symptoms, we'll talk about non-pharmacological symptom management strategies, and you're going to get an exercise program and be taught how to exercise best with MS. And then I like to tell my patients that you're going to use me like you use your primary care doctor for your annual physicals, right? So you're going to come in and you're going to do checkups with me, because it's a lot easier for you to be reevaluated and have problems kind of nipped in the bud before they become too big. So we can kind of address subtle things. Maybe there's a new increase in a symptom or a new symptom that maybe we can kind of tamp down without adding a medication. Maybe your exercise program needs to be changed. Maybe you have different lifestyle needs, and we need to talk about that. Maybe you're caring for a child now and you need to be, lifting babies and having good balance. So there are things that we can do throughout the course of the disease. I think the question really lies at later on in the disease, is there any benefit to therapy? And I think it goes back to what we have talked about earlier, that it's not just MS. You can have arthritis, and you can have hypertension, and you can have any number of things that aren't necessarily being fully addressed or being blamed on your MS that we need to address. And it may not be at that later phase that you're always looking for this huge improvement. But if you're not working on the skills that you have to maintain them, then you're going to be backsliding. You'll become deconditioned, you'll become weaker. And so it's really important. And it's hard to stay motivated and consistent, but that's where a therapist can help you along, building a program that's doable for you so that you can feel successful. So along the whole trajectory of the disease.
I had somebody also, just to piggyback on what you're saying, and she was going to go on a vacation where there was going to be extra walking that wasn't typical for her day to day. And she went to see her physical therapist to prepare for the vacation. Is that something that you would recommend as well?
Absolutely. A lot of times I get people coming back to therapy because they're like, oh, my daughter's getting married and I'm going to be walking down the aisle and I want to wear a little kitten heel, so, we really want to work on your very specific goals. And I really haven't talked a lot about during the course of this webinar about safety and assistive devices, but assistive devices, it's always a transition when we have to move to an assistive device, but it can help with energy management. You don't have to work so hard on your balance. If it saves a fall and it saves a broken bone, I mean, something like that can really change the course of how you're going to move forward with your quality of life. So having the right assistive device, meeting with a therapist who can, that you can demo a lot of these products with is really important, because a lot of my folks have a closet full of stuff that they bought on the internet that just didn't work for them. And possibly if they had some advice or a trial of the equipment, we could have picked something that was a little bit better, especially if you've used your insurance to pay for it. They're pretty much one and done. And you bought this, you're not going to get something else in its place. So.
And I also want to say, if your healthcare provider says, I think you should use a cane because I'm concerned about your falls, it's probably the best idea. I mean, we wouldn't do that lightly. And so many of our patients, I mean, a number of our patients saying, oh, I don't need it. And then they're holding on to the wall coming out. So
Yeah.
something like that we're just trying to keep you safe. And
Yeah.
not that we think using a cane would make you look whatever, disabled or whatever, but it's safety that we worry about, your safety.
Right. I think too that meeting with your rehab professional to try out some different things is really
Such a great
beneficial,
idea.
because like I say, I'm in Colorado. Trekking poles are all the rage and they work really great. So if you want to use trekking poles in place of, a cane or crutches, we can work with that, So we want to pick a device that not only will make you safe, but aesthetically something that you can accept.
Right.
Now, Pat, one question. Oh, sorry.
I often go ahead.
I just had a quick follow-up question, because actually pretty frequently I have patients asking me about the Bioness and other devices.
Yeah.
Do most physical therapy offices have the ability to trial things like that with patients, or is that something a specialty office would be required for?
Yeah, most neurological physical therapy departments would have access to them. If they don't have the product themselves, then they can contact the company, and usually we can get a demo in, but that has to be scheduled in ahead of time. Um, uh, some of the other devices, you sometimes don't have a clinic model. The patient purchases it, and then comes back to therapy to work with it. So that's a little bit of a model that maybe, will have to be tweaked a little bit. But most neurological clinics will have an access to it if they don't even have the equipment in the clinic themselves. Good question.
Just as the therapist or the psychologist here, using assistive devices can be also something that people resist, as you just said, Mary Jean. And I often ask people to think about those values again that I brought up in the beginning, and whether the choice they're making is widening their world or shrinking their world. And if it's important to participate in an activity with your family outside of the house, and that means that you're going to have more energy and be able to do that activity for longer in a safer way or in a faster way to keep up with your kids or spouse or something like that, then maybe the assistive device is the right choice in that moment. At other times, when you want to strengthen or when you want to work on your balance, maybe using the assistive device is not the right time to use that. And talking with your physical therapist can help you to make those choices as well.
I think that that's really important, Megan, just to piggyback off of that, is that um, nobody wants to be forced to use an assistive device. They're ready when they're ready. But if you can work with the situation and work with the device and kind of work over time to see how it might be beneficial, that's a much more palatable way to accepting an assistive device than saying, you have to use this.
Megan, I was hoping you could share some mental health resources for patients and their care partners.
Sure. So I obviously, as a psychologist, think that everybody could benefit from working with a mental health provider, but I know that that's not always feasible. Time commitment, financial commitment, maybe you can't find somebody in your area. So I would encourage people that if you are looking for resources that are outside of working with a one-on-one therapist, resources that I really like, I'm going to list off of a few, and these are ones that I recommend to many of my patients. Not all of them are MS specific, but they all would be applicable to many of the challenges that you might be facing. So programs like this are important. Can Do Multiple Sclerosis is a great resource. They have coaching sessions. I Conquer MS is a great resource. They also, both of those have resources specific to care partners. And care partners often have their own mental health challenges and would benefit from their own mental health support. So don't push away your needs if you're a care provider on this call. Your needs are just as important as the person that you're supporting with MS. I really like two different books. One is there's a series of books called Treatments That Work, and there's one specific to chronic illness in CBT or cognitive behavioral therapy. It's a manual that you can, or a workbook that you can use yourself. You could buy it on Amazon. It's called Treatments That Work. Another one is called Get Out of Your Mind and Into Your Life. That's an acceptance and commitment therapy workbook that I really like. There's also apps and websites that can be really effective. The FDA has cleared a few. One that I know of off the top of my head, given that we talked about insomnia and sleep earlier, is called Sleepio, Sleep.io, basically. And that walks you through a manualized procedure of how to address sleep problems. And often there's a lot of great research that cognitive behavioral therapy for insomnia is very effective in MS. And another website that I really like, and I'll stop after this, I could keep going, is called dialecticalbehaviortherapy.com. Again, not specific to MS, but they're very short 5-minute videos with worksheets on different coping techniques that you can use in multiple domains of life with social interactions, with emotion regulation, with just problem solving. So you can kind of go onto that website, kind of find the category that you might need the most support in, watch the 5-minute video, do the practice session. I think it's a really great resource that I often use in conjunction with the therapy that I work with people on, but people can also use it independently.
I will second the CBT for insomnia. I often recommend that, but the problem is that I practice in a rural area with very little specialty care. Do you have any online resources? And it's like kind of off the top of your head. If not, that's okay.
Yeah, so the app that I mentioned, Sleepio, is one. It does cost money though. So if you're looking for a free resource, I think it's called freecbti.org or .com. If you Google free CBTI, the website is not the prettiest, but it does have all of the segments and all the things that you need. It would walk you through sort of some worksheets. Basically, like if you were working with a CBTI specialist, it would walk you through the different sessions that they would do with you. So I would check that out. I might be getting that wrong, but if you Google freecbti.com or .org, I think it will come up.
Excellent. See, we're all learning tonight. And kind of to piggyback on the last question, are there things that people living with MS can do to help their family, friends, or coworkers understand what it's like to live with MS?
I often find that going to medical appointments can be really valuable. That way, they can hear what's happening from the medical professional. They also often get an opportunity to ask their own questions. I also often think about I've done some speaking for Can Do Multiple Sclerosis, and there was a program a while back where somebody came up to us at the end and said, my partner or my spouse always talked about this fatigue thing. And I just thought, well, like we're all tired. But then hearing from all the other people in the room about fatigue, it really made me realize like this is a real thing. And so I often think that if you can go to programs that include a care partner, like Can Do MS, and they're not the only ones. They're just the one that I do the most work with, so I advocate for them. Uh, that can be very powerful because it gives them the opportunity to hear from somebody outside of, the main person living with MS in their world.
I will second having your care partners, family, or your support people come with you to your medical
Yeah,
appointments.
me too. Yeah.
Awesome.
Especially
Yes.
if you have trouble remembering everything that was said, it's always helpful to have another set of ears to listen to everything that's discussed and again, be able to ask their own questions.
Yeah.
All right, and we received a question about resources for lower income patients or practices with limited resources. So I will take a stab at this as I am trying to build an MS center in a very rural area with very little specialty care. So I have, as you saw tonight, kind of try to find free online resources for some of my patients. I do often send people to the National MS website. They do have a MS patient navigator program where patients can get assistance with various questions they have about MS. I've also found different strategies to get patients who are uninsured or underinsured affordable medications, and that's primarily using GoodRx coupons, which is patients just have to sign up for an account online, as well as the Cost Plus Pharmacy, which is Mark Cuban's pharmacy, and that does not require neither of those options require insurance. And I think the Cost Plus Pharmacy is actually an excellent pharmacy. They even offer disease modifying therapy, primarily the oral therapies, the generic versions, for like $20 to $30 per month, some of them, out of pocket with no insurance. So I have found that a really helpful tool to get my patients who are uninsured some sort of disease modifying therapy for their MS. And then they also carry a variety of symptomatic medications that I use. So I would say those are my biggest recommendations. And then beyond that, just trying to learn in my community who are people I can send my patients to. Who's the urologist that I'm going to send all my patients to? What is the best physical therapy office? They maybe have someone with a neurology background or is interested in learning. And this, some of those things I'm still learning. I haven't even been, it's almost been a year. So, it does take some time, but it's certainly challenging operating in an area with limited specialty care. And I think a lot of reliance on online resources has been easier since COVID because that sort of normalized the telehealth with your provider, but getting mental health resources, that counseling, therapy, it really normalized seeing a therapist through Zoom or on your phone instead of in person. So I have sort of relied more heavily on those kind of resources.
And I'd just like to say, at least for the mental health side of things, there is something called PsyPact for psychologists that allows us to see people across state lines, I think in up to 42 states now. And the social work and counselors are not far behind us. They're creating their own state compacts so that they'll be able to see people across state lines very shortly. So if somebody is not in your specific area and you're willing to see a mental health provider um, over Zoom, you can look in a lot of the major MS centers around the country will have a psychologist attached to their practice. And I know Johns Hopkins, where I came from, uh, we would see people outside of the state of Maryland. So contact those MS centers and find out if there's an MS specialist if you want to. You might be able to see somebody who's in a completely different state and still get the care that you need.
And another thing we didn't touch on today is the importance of a primary care provider. Somebody who's going to take care of you for the regular stuff. I know many of my patients say, well, you're that person. And I say, no, I'm not that person. You need your flu shot. You need your blood pressure checked. You need all this stuff done, the regular screenings that we in the neurology world don't do for you. We do your MS stuff, but there's so many things. You need a PSA done if you're an older man. You need your mammograms done. We don't do all that. So make sure you have somebody that you see once a year or whenever that can take care of those regular screening things that are so important, because if they do say, okay, now you have this disease, well, then we'll know that too, and we'll all treat you together. So I think that's really important.
I know that there's a lot of appointments, but also, Mary Jean, like dental care. Dental care is really huge, right? So a low-grade infection in your mouth can give you a lot of different symptoms that you might be blaming on MS. So, complete comprehensive care.
All right, excellent. Well, I think we're going to move to some of the questions we've received during the webinar this evening. So the first question that we received was about the Pipe 307 that Mary Jean mentioned earlier and whether it's a CAR T therapy. So I suppose we could also cover what the answer is no. We could also cover what CAR T therapy is. So this is a investigational therapy which has been used in oncology, but where someone's blood is taken and basically you have two types of immune cells, white cells. It's the T cells and the B cells. Initially, way back when, we thought MS was primarily a T cell disease, and now we found, well, actually taking out the B cells works pretty well to control it too. So they're both very important. But what the T cell therapy does is it takes your own cells and then targets them to take out the B cells. So in some sense, it's kind of like a Ocrevus or Briumvi on steroids. So those medicines are antibodies that target the B cells, and then your body removes the B cells. A CAR T therapy is just making your own cells target those B cells. So it's sort of similar mechanism. Pipe 307.
Totally different than Pipe 307, which is trying to replace myelin and stuff like that. Totally different.
The next question we received is about labeling the diagnoses. And is it common not to be labeled with a specific diagnosis? This particular person is reporting worsening for 7 years, no flares, and the specialist is not sure if it's relapsing, remitting, or primary progressive. And I think as an MS community, we are moving away from labels, which can be very confusing because for so many years, and still our insurance companies require us to categorize people in order to get medications approved. But we have learned over the last decade that what we thought was primary progressive, secondary progressive, it seems like there is probably progression happening along with relapses for many people. And so it's not quite clear if it's not as black and white as labeling somebody relapsing, remitting versus secondary progressive. And when does someone start to progress? Well, what if you've had kind of some gradually worsening cognitive symptoms for years? And so it can be very challenging. That being said, like I mentioned, the insurance companies are now, unfortunately, as of a month ago, requiring us to label you
4 different ones, all these
Yeah.
different ones. You're like, what?
In order to get your medications covered.
That's
And
right.
so they're a little bit behind the times, they're a little bit behind the research. But for most of our medications that are approved for relapsing remitting or active secondary progressive, which means that you're having progression along with relapses. And as Mary Jean mentioned earlier, we're looking forward to the BTK inhibitors as potentially the first class that will be indicated for non-active secondary progressive MS. But it is sometimes not clear. And so, in terms of this question, it's hard to know. And sometimes I have met patients who have been labeled relapsing remitting, and I talk to them and I say, hey, I actually think maybe you were primary progressive based on your description, and maybe the therapy you're on is maybe not the best one for you. So yeah, I think it's complicated.
And a lot of it is what you tell us. That's really how we make the diagnosis. What do you tell us at that first visit? Did you have a flare? Did this happen? Did that happen? Some people don't remember a flare. Then they go, oh yeah, when I was 18, I had this problem, and now it's 10 years later. So we really bank on you to tell us what you're going through, because history, we call that the history, is like 85% of the diagnosis. It helps us get in the right mindset. So what you say to us is so important. So make sure you say it.
Yeah, and I often tell people, you'll tell me when you're progressing. If
Right.
you're in a relapsing state and you start to tell me that things are getting gradually worse over time, you're telling me. I won't tell you when you're starting to progress. That being said, if someone comes in and say, hey, I think I'm starting to progress or I'm gradually getting worse, there are a few things I want to do before I'm going to label you as having progressive disease. And that is make sure you don't have any infections or things that are worsening your symptoms, send you for physical therapy and make sure you're not deconditioned, because those can certainly mimic progression. Make sure there are no other reasons why you're having trouble walking. Like I mentioned earlier, your hips and knees, or there are other issues that are contributing that are not related to the MS. So um, it's a little bit of it's mostly based on what you're telling us, though. All right. And then the next question we received was about Ocrevus, and last MRI with a new lesion on the neck. Is this normal? Well, I will say that all of our medications, although we have really good medications, none of them are 100%. And certainly we don't expect to see many lesions or a lot of disease activity on some of our highly effective disease modifying therapies, but it does happen. It's not common, it happens. I wouldn't say it's normal, but certainly I don't know, and it's kind of really dependent person to person. So I can't really weigh in on the specific situation. Um, it's going to be a discussion with your provider or whether that's considered a failure of the treatment or whether you just continue to monitor.
Right. We have to look at the big picture with you.
All right. The next question is about regarding our thoughts on Mavenclad. Uh,
Good
I,
drug.
Yeah, I mean it's effective. I will say I tend to use it mostly in people later in their disease course, like in their 50s perhaps, as their last disease modifying therapy, to get off of therapy. Now I know different people will practice in different ways. So if you ask a bunch of neurologists this question, they're all going to have different answers for you. Some people love Mavenclad, some people hate Mavenclad. And so,
It's like any other drug. Some
yeah.
people like this one, some people like that. That's true. True.
But I mean, the thing that people like about it is it's not continuous immune suppression, right? So you're going to be relatively immune suppressed for a few months. You do that again a year later, your immune system recovers, and then you're not immune suppressed. So there is that makes it a little different than some of our other therapies. All right. The next question was, after a first attack, do you expect to have other attacks on the same area, like a leg? Can the attack produce a different sensation from the original? I never say never with MS. MS can do anything. And
Yes, of
certainly
course.
in the spinal cord, you can have a lesion adjacent to another old lesion, slightly different symptoms in a very similar area. So yes, the answer is MS can do almost anything.
Right.
All right, and then thank you. Oh, you're welcome. In North Carolina for 10 years, support groups are very important for us. I wish all doctors can come to a group once a year. Yes, I think support groups are great, and honestly, it's something I'm eventually would like to have set up in my area, but I have to focus on one thing at a time. So right now I'm trying to grow the MS Center and get some mental health resources and support as well. I do think to do a really well-run support group, it is important to have mental health resources available, especially if people are having a troublesome time or they're really struggling. Having someone to be able to send them to or refer them to, or even help lead the meeting if possible, is great. But yes, having physicians that understand what you're going through is super important. All right. I didn't know if any of the other panelists have anything else they'd like to add or any questions that we wanted to expand upon but didn't get a chance.
For anybody who's, I think maybe they're already participating in a support group, but for anybody who might be starting one or thinking about starting a support group, the National MS Society has some great resources where they lead you through, I think it's like an 8-week session. I might be getting that wrong, but they give you some stuff to read, questions to talk about. And so sometimes having a structure like that can be really helpful, and especially in terms of pointing towards the resilience piece rather than, I often hear people that don't always want to go to support groups if they feel like they're very negative, or it's hard to talk about problem solving. And so having a resource like that from the MS Society might be a great way to kind of focus on what you can do.
I think the other thing that I wanted to add is that you may not have, as Dr. Roman said, a rehab specialist in MS in your area. There's a certification, MS certified specialist, but we're few and far between, and a lot of us aren't in rural communities. I always suggest that you interview the therapist that you're going to be seeing, and it's all right to ask them, like, what is your background? Do you know anything about MS? Do you have any experience in neurology? Do you have an interest in learning about my disease and working with me on my journey through this? So even if you don't have somebody in your area who's an MS certified specialist, finding someone who'll take an interest and learn about the disease and help you along the way is a really good strategy.
Thank you, Patty. That actually brought up something that I'd like to leave the attendees with as well. And that is something that had come up quite a lot when I would do my social media patient education. I would often hear patients say things like, I don't feel like my neurologist is listening to me. I don't feel like we're partnering together. 'Cause some of my symptoms and complaints are being dismissed. And I always tell them, you have the opportunity, you have the freedom to get a second opinion. You are always welcome to see another neurologist if you should really be feeling like a partner with your neurologist. And if that partnership is lacking, no one's feelings are going to be hurt if you go and find another neurologist that you maybe click better with. And so it's really important for your overall long-term health to find someone who's you're going to be able to work with long term.
Agreed.
Excellent. Well, I guess we'll go ahead and wrap up. I just wanted to thank all of our panelists for participating tonight and all of our attendees for joining. This has been a really lovely conversation this evening.
Thank you.
Thank you.
Thank you, Samantha, for leading us off.
Of course.